Hello everyone, my name is Frédéric Michard, I'm from Lausanne, Switzerland. So before I start, I'd like to disclose the fact that I'm today leading a consulting and research company based in Switzerland and where we focus on digital innovations with medical applications. So what are the clinical needs for blood pressure monitoring? I think first of all, we need more accurate brachial cuff. You know very well that the brachial cuff we are using in the majority of our patients are not very accurate to measure very low or very high blood pressure values. And that was very nicely illustrated by this study from WACS, a large number of non-cardiac surgical patients where they compared invasive reference measurements to measurements coming from a brachial cuff. So you may have seen this paper published just a few weeks ago in anesthesiology where they compared measurements done with a new brachial cuff, a high-fidelity brachial cuff, to reference invasive measurements. This is a new brachial cuff. What's really different is that it has a rigid conic shape and case, and maybe more importantly, sensor, a hydraulic pad or a sensor filled with liquid. And so it's very important to understand that air is usually used as a shock absorber and damper. And so in black, you get an idea of the signal we record today with a classical brachial cuff. And so in blue, with this new sensor filled with liquid, a hydraulic sensor, that's what you get when you record the blood pressure signal. So a dramatic improvement in signal-to-noise ratio, the reason why they call it or they describe it as high-fidelity brachial cuff. So in this study where they compared measurement done with the new brachial cuff to reference thermal invasive measurements, they report a very impressive relationship. This is a blinded man, which is interesting to look at just to see that the bias does not increase for very low or very high values in contrast to what we observe with classical brachial cuff. And this is a 4-quadrant plot showing that the non-invasive technique is also very accurate to detect changes, a decrease or an increase in arterial pressure. The second need I think we have is we need more information. What I mean by more information is we need to know about the determinants of blood pressure, because when the blood pressure drops, it's very useful to know if it's related to a decrease in blood flow or a decrease in vascular tone. And if it's related to a decrease in blood flow, it's very useful to know if the patient is fluid responsive. So we need more information than just the blood pressure. And as a matter of fact, when you look at techniques today available, the volume clamp methods are interesting because they give us not only continuous information about blood pressure, but also the determinants of blood pressure, blood flow, and vascular resistance. However, it's important to acknowledge that outcome studies published so far with these techniques have been a bit disappointing. This is, I think, the first one done by Christabor, the team of Christabor, and published in Anesthesia a few years ago. It's a randomized control trial, 244 patients, and they did not observe any difference in terms of complication rate, postoperative complication rate, after the implementation of one of these new systems. This is a more recent study from the team of Simon Davis in New York, in the UK. I mean, they used one of these volume clamp techniques for patients undergoing a surgical repair of a proximal femoral fracture, and again, they failed to observe any significant improvement in postoperative outcome. So what could be the reason for that? First of all, I think these techniques are probably not always as accurate and precise as we would like them to be. And this is a very recent meta-analysis of validation studies of these finger cuff or volume clamp techniques. And you see that only 33% of these studies had a bias below 5 and a standard deviation below 8 millimeters of mercury. And these are the international standards today for blood pressure monitoring systems. And regarding cardiac output measurements, only 21% of published validation studies showed a percentage error below 30%, which is the cutoff value proposed by Critchley, or only almost half of validation studies had reported a percentage error below 45%, which is probably a more realistic threshold. And clearly, I mean, these techniques have limitation in patients with a decrease in peripheral perfusion, which is often the case actually in case of shock. We don't have a good signal and then they become less reliable. And actually this recent study published in PLOS ONE is very interesting because it shows that the perfusion index you get from your pulse oximeter can tell you if you can rely or not on volume clamp measurements. The other issue we may have, or which may explain the disappointing results of outcome studies, is the fact that non-invasive tools are usually evaluated in patients who do not have or do not need any line. And so in low to medium risk patients, postoperative outcome is usually uneventful, and showing an outcome benefit in this context becomes, of course, very challenging. And I think it's nicely illustrated by these recent studies. So it's not yet published, but it was presented last year during the ASA Congress. So it's an implementation quality improvement program done in the US, led by Matt McEvoy from Vanderbilt University. And what they try to do is to use one of these volume clamp techniques in addition to all the elements you know from enhanced recovery program in colorectal surgical patients. So a pretty low morbidity rate from baseline, and so they failed to show any benefit. So it's obviously easier to show value in high-risk situations where patients often develop postoperative complications than in this context. But I think the third big clinical need we have is possibly continuous and mobile monitoring on the wards. So you may say, why are you talking about the wards? We are more concerned about what's happening in the OR, in the ICU. There are many studies like that one showing a very strong association between intraoperative hypertension and postoperative morbidity, for instance, here, acute kidney injury on the right-hand side or myocardial injury on the side. And because of this body of studies showing a strong association between intraoperative hypertension and postoperative outcomes, some groups started to develop strategies to decrease the duration and the depth of hypertension during surgery. So this is an example. This is a study from a group of Dan Sessler. They started to use a volume clamp technique to monitor continuously blood pressure. And their expectation was, okay, by detecting immediately when the blood pressure drops, and they would be able to decrease the average duration of hypertension. And this is exactly what happened. You see that whatever the threshold you are using to define hypertension, they basically cut by half the average duration of hypertension. But you know the saying, a difference to be a difference must make a difference. And when they looked at outcome variables, postoperative outcome variables, the postoperative morbidity score was basically exactly the same in the two groups, as well as hospital length of stay. So of course, I know very well this study was not designed to show an outcome benefit, but we're still with 300 patients, we should start to see trends if there is an effect on postoperative outcome. This study is also very interesting. It was published in the JAMA a few months ago. They used, this new machine learning-derived early warning system that predicts hypertension. And so the idea was that if you can predict hypertension, you can possibly be proactive and prevent hypertension, or at least decrease the average duration of hypertension. And this is exactly what happened. As you can see, 32 minutes on average in the control group. It dropped to 8 minutes in the intervention group. But once again, when you look at the adverse event after surgery, no difference. So what could explain these findings? How could it be? I think the explanation is that postoperative hypertension matters much more than what's happening during surgery. And we started to realize that when Sessler published this paper 3 years ago in anesthesiology. This interesting study showed again that if you focus on intraoperative hypertension and look at myocardial infarction and death after surgery, you find an association. And clearly developing hypertension during surgery is going to increase by 8% on average the risk to develop myocardial infarction and death. But if now you look, and that's what they did, at the influence or the association between postoperative hypertension between day 1 and day 4, when most patients are on the wards, and myocardial infarction and death, then you find a 183% increase. So obviously what's happening after surgery has a dramatic impact on postoperative outcome. And this was recently confirmed by a paper published in anesthesiology a few months ago, where, and again, they showed that postoperative hypotension is strongly associated with myocardial injury after surgery, whatever the definition you are using for hypertension. But in contrast, if you adjust for postoperative blood pressure values, then intraoperative hypertension is not anymore associated with postoperative myocardial. So clearly what's happening after surgery is absolutely key. And after surgery, most patients are on the wards, where nurses are doing spot check of vital signs, usually every 4 to 6 or 8 hours, including blood pressure. And so we know from this study published in Anesthesiology last year that because nurses are spot checking, or when nurses are spot checking blood pressure only every 4 hours, they miss around 50% of hypotensive events. So when patients develop hypotension on the wards, usually it is undetected, and then patients may remain hypotensive for hours. On the wards, to monitor blood pressure or to detect changes in blood pressure, we can use pulse wave transit time methods. You know the principles. You need electrodes to detect the ECG, and you need a pulse oximeter to detect the pulse oximetry waveform, and then the time between the peak of the airwave and the ECG and the beginning of the peripheral pulse is a pulse wave transit time that depends on blood flow and that depends on vascular tone. So anytime you have a change in pulse wave transit time, you very often have a change in blood pressure. So it's a way to predict blood pressure, or I think more reasonably, to trigger a new blood pressure measurement with your brachial cuff. In the future, we can imagine to use machine learning methods to track changes in blood pressure on postoperative, during the postoperative period. This is a recent study from Dr. Gamry and Patrick Schottker from Lausanne. They used a machine learning system, so they fed the system with a large number of pulse oximetry waveforms, and then the system learned how to recognize specific patterns observed during changes in blood pressure, and then in this clinical study, they showed that the algorithm is actually pretty accurate to detect a decrease or a rise in systolic and mean arterial pressure. Other sensors are also coming to market. This is an example of an electromechanical sensor that could be part of a small bracelet. This is actually what we are going to be able to do thanks to new materials, nanotechnology, and flexible electronics. This is an example of a very tiny ultrasound patch. Of course, it's not designed to be positioned on the joint, but it's just to show you what it looks like. That's actually something you would put on the carotid artery or the brachial artery or the radial artery to measure blood pressure continuously. This is another example with a piezoelectric wireless sensor that we could possibly use in the future to monitor patients on the wards. Video monitoring might be an option or become an option as well. As you know, the concept is to turn cameras into health monitors. There are already devices measuring your heart rate and respiratory rate, able to detect cardiac arrhythmia just looking at your face or estimate SpO2. This is a new software which has been developed. It's actually implemented on a smartphone, and just looking at your face, they claim they can monitor your blood pressure. So, in conclusion, high-risk surgical patients and ICU patients with shock still need an align. It remains the reference technique, and it's, by the way, very convenient in this context to draw blood samples. We need anyway. Brachial cuff have recently been revisited, and so it's going to be very interested and to gather the feedback of clinicians who will have the privilege to use them when they will become available on the market. Knowing the determinants of blood pressure may help and should help to make the right therapeutic decision, but you saw that outcome studies published so far have been disappointing. But I think the key message of my lecture is the following. We need to focus now on the wards where hypertension is common, often goes undetected, and is strongly associated with complications. With that, I thank you very much for your attention, and if you are interested in the topic, I invite you to read this editorial I recently published with Thomas Sheeran and Bernd Sogel in the British Journal of Anesthesia. Thank you very much.